Dr. Antariksh Vijan. He is MBBS, MD, radiologist. He's a gold medalist. He's FPIR, vascular and laser interventional radiologist. He is performing varicose vein treatment, PAD interventions, DVT management, AVS salvage, aortic aneurysm repair, and tumor embolization. He has an expertise in minimally invasive approach that ensures effective limb salvage in vascular care. Today's topic is novel advances and applications in interventional radiology. We welcome Dr. Antariksh Vijan. I believe it's your first lecture with BMB. We welcome you to BMB, but definitely not your last lecture. Welcome, sir.
Thank you so much for that lovely introduction, madam. And of course, it's my first time here at the Borivali Brotherhood, and hopefully not the last at all. With that, we'll delve into the topic for today, that is novel applications of interventional radiology in peripheral vascular interventions. So just to give you a bit of background, we're coming very soon close to you at Heart and Vascular Super Specialty Hospitals with our ethos of protecting the flow of life. Our mission is to have dedicated small format cardiovascular units in the form of a state-of-the-art cath lab with critical care facilities and admission facilities for the same. Without further ado, I would like to just highlight on what the scope of interventional radiology actually is. So this is an introductory slide that I think warrants some time. So, what exactly do we do in IR? So our job is to drain or to divert. That is, drainage of any fluid collections, whether it's pleural, ascitic, pericardial, any liver abscesses or percutaneous cholecystostomies as well. Drainages in the form of biliary diversion or percutaneous nephrostomies as well. Second is to sample tissue with accuracy, that is doing image-guided biopsies using ultrasound or CT scan, whether it's a neck node, mediastinal node, liver, kidneys, all of these can be sampled accurately using ultrasound or CT guidance, even the pancreas. To close undesirable vessels, that is, if there are any additional vessels that need to be ablated, for example, in varicose veins, where you have vessels that are not meant to be there, we ablate those. Or to embolize arteries, that is, those arteries that have developed for tumors as a feeding artery, that can be embolized using interventional radiology. To open desirable vessels, that is, to revascularize. So those vessels that are desirable, for example, your lower limb arteries, and if they have calcification or stenosis, those can be revascularized. Or for example, in fistuloplasties, where if a fistula is stenosed, we can re-establish flow across that. Next is to ablate tissue. So for example, in tumor ablations, that is lung nodule or liver metastases ablation, or even thyroid nodules, for example, for goiter. To access blood, so that is venous accesses. So various central venous access devices can be placed under imaging guidance, such as a PICC line, that is a peripherally inserted central catheter, central venous access devices like a permacath for dialysis, and even arterial accesses can be established for the same. So with that background, I'll delve into the topics for today, which is varicose veins, the latest advances, management of DVT, what's new on the block, and peripheral vascular diseases, what's new. Varicose veins. So we know this is a very familiar picture and a very graphical representation of an ulcer just above the medial malleolus of the foot in the classic gaiter zone. We can see there are multiple congested varicosities just proximal to it, resulting in this stasis ulcer. So why exactly does this happen? Just to highlight in brief, the anatomy of the lower limb venous drainage. We have two superficial veins, the great and the short saphenous veins. These drain into deep veins, that is popliteal vein and the femoral vein. The two superficial veins normally must only take 10% of the venous drainage of the blood back to the heart. The rest of the 90% is via the deep veins. There is a valve at the junction of the great and the short saphenous vein with their respective deep veins. When this valve becomes leaky, the blood begins to pool in the superficial veins of the leg, resulting in varicose veins. So with that background, I would like to highlight something very important that some of us may not be familiar with, the CEAP classification for venous disorders. So the C stands for clinical manifestation. That's the most important column here. The etiology is the E, anatomical classification, and the pathophysiology of it. In this, I would like to highlight C1 is the mildest form of lower limb venous disease, and C6 is the most active form or most severe form of it in the form of an ulcer. Our goal in treatment of varicose veins is to catch it at C2 and prevent it from progressing to C6. So what exactly is C1? C1 is the most common thing that we may see in the form of spider veins. So the spider veins that we see in the lower limb are actually reticular veins or telangiectasias, and these do not need treatment from a medical point of view. I repeat, C1 is plainly cosmetic. These are the spider veins. The treatment for this is not advised medically. However, C2 to C6 onwards is something that warrants treatment. And the treatment is actually medically indicated, whether that's conservative or it requires a procedure. That depends on a case-to-case basis. But if we have symptomatic varicose veins in the form of edema, skin changes, or any ulcer, whether healed or active, that warrants treatment. Just to clear some terminologies, what are varicose veins? So dilated veins more than 3 mm classify C2. So if we see dilated veins in the lower limbs that are more than 3 millimeters in size, that classifies in the C2 category. Veins that are less than 3 millimeters in size are either telangiectasias when very small or plain reticular veins, and these do not warrant treatment, just clinical observation. So what are the symptoms in varicose veins? So one we discussed is the engorged and dilated veins more than 3 millimeters in size. That is the C2 category. But many of our patients have these for 10 to 15 years. Do all of them warrant treatment? So what are the symptoms that we must watch for? Heaviness or cramping in the lower limbs, particularly nocturnal. Second would be sometimes a burning sensation can be there in the lower limb because of venous congestion. Edema can be there. And of course, features of chronic insufficiency. Many times patients actually present with an RLS-like picture, that is restless leg syndrome. So, of course, iron deficiency is associated with that, but many times this may actually have a subclinical varicose veins that's resulting in this symptom. So we can actually offer them stockings and that may actually help them. To highlight chronic venous insufficiency that we saw there, what exactly happens? Like we discussed, we have the superficial veins, perforators, and the deep veins. There is a valve at the junction of superficial vein and the deep vein. When there is valvular incompetence over a period of time, the blood begins to stay static in the superficial vein, and from there it extravasates into surrounding skin and subcutaneous tissue. This results in formation of hemosiderin pigment in the skin and the subcutaneous tissue, resulting in pigmentation, and because of the pigment, irritation as well, resulting in itching and even lipodermatosclerosis, that is skin thickening. That is the reactive response to the hemosiderin pigment within the skin and subcutaneous tissue, resulting from venous stasis. The etiology that we must look at is age-related valvular dysfunction, immobilization because of gravity-dependent stasis of the blood, obesity, prolonged standing, that's the most common, and secondary to DVT. So DVT causes valvular damage, resulting in a chronic reflux. This is a classic picture of chronic venous insufficiency involving the medial malleolus and the lower third of the leg in the form of pigmentation, atrophic blanching, that is the area where there is no hair and loss of pigment, and lipodermatosclerosis seen as skin thickening. With that background, how do we manage varicose veins? To summarize, class 2 medical grade compression stockings are the treatment of choice. Class 2 means it gives a pressure of at least 15 to 25 millimeters of mercury. If we are not giving a medical grade class 2 compression stockings and just something over the counter which is going to give a pressure of less than 5, it is going to be ineffective for the treatment of varicose veins. We must make sure that when we prescribe stockings, we specify class 2 compression stockings, medical grade. So basically stockings are 1, 2, 3. Class 1 gives a pressure of less than 10. Class 2 gives a pressure of 15 to 25, and class 3 is the DVT stockings, which gives a pressure of more than 25. So for treatment of varicose veins, we must stick to class 2 compression stockings. and we can additionally supplement that with some venotonic agents. So this, we are familiar with Daflon 1000 milligrams. That's not just a hoax drug. It's actually an inhibitor of thromboxane A2. So because of inhibition of thromboxane A2, the diosmin and his hesperidin component actually results in improved tone of the vein, facilitating drainage towards the heart. When this fails, the treatment of choice is endovenous laser ablation. That is the gold standard in the form of EVLT. Jokes apart, we have multiple data right from 2022 to 23 to 25 in the form of various consensus statements that has gone outright and said a big no to venous stripping or high ligation of the GSV. The treatment of choice as per all international recommendation is endovenous thermal ablation as the first choice treatment in preference to any other surgical or sclerotherapy modality. This is internationally established, robust scientific data which has gone out and said EVLT is the gold standard for treatment of varicose veins. With that, I'll just like to go and show what is new. So VenaSeal is the new kid on the block, and when not to do varicose veins treatment. So before that, just to show you, this is how we do a standard EVLT. After good adequate part preparation, we access the short saphenous vein, in this case, for example, and place a sheath in it. Similarly, we access the great saphenous vein under ultrasound guidance and place a sheath within that. Then we take the laser fiber, introduce it throughout the vein, and seal the vein shut with the help of endovenous laser therapy. To do that, with the help of multiple needles, we inject something called tumescent anesthesia. That is a mixture of sodium chloride with lignocaine and bupivacaine. And with that, we collapse this vein over the laser fiber. This facilitates contact of the laser fiber with the vein and helps us to give an adequate thermal ablation to that vein. Just to show you an illustration, this is the vein, this is the catheter within it. Once we do that, we inject saline and local anesthetic in the form of tumescent anesthesia and collapse the vein over the laser fiber, resulting in the endovenous laser ablation. So this is the gold standard, such a perfect procedure. Why do we need a new kid on the block, right? What are the rooms for improvement? So one is the tumescent anesthesia that involves injecting 10 to 12 times along the course of the vein. So that the vein can collapse over the laser fiber, like I mentioned. So this can result in some bruising post-procedure and can actually warrants thigh-high stockings post-procedure. We all know what the compliance is with that. Thigh-high stockings and patients with varicose veins don't do well together despite best counseling. So that is one part of it. Second is post-procedure, like we discussed, the compression stockings. And third is a less than 1% chance of some thermal nerve injury does exist with any thermal ablation. So to circumvent that, VenaSeal closure system came into existence where we use medical grade glue, to seal the vein shut. Okay, so I have a video there that is not playing. Okay, that's fine. I'll skip that. Right. So the clinical evidence for this, so we have robust scientific data that shows us that for up to 240 patients who underwent VenaSeal procedure in a prospective trial have a closure rate of more than 95% at 1 year and up to 95% at 3 years. So that's pretty good data, that 95% closure rate for up to 3 years. Another trial for 1 year, the WAVES trial with up to 1 year data showed a 98% closure rate of the great saphenous, short saphenous and accessory saphenous vein as well for a size up to 2 centimeters. So that is good data. Without further ado, another study for up to 5 years post-procedure data shows us that the closure rate was good with sustained improvement in symptoms and quality of life. So we have robust scientific data backing up VenaSeal in the form of prospective multi-center trials that show that VenaSeal is equivalent, if not better, than the present modalities. The benefits of VenaSeal is eliminating the need for the tumescent anesthesia, allowing us to give compression stockings that are only knee length, which is much more comfortable and has better compliance for our patients. Second is no post-treatment risk of thermal injury. So like we said, in any thermal ablation, there's a less than 1% risk of thermal injury, and that is eliminated with Vinacine. With that, I'll delve into a little bit about when not to do varicose veins treatment. That is, when is there something else at play? I have 3 short clinical cases. This was a 34-year-old female. We can see there are huge dilated varicose veins, but these don't seem to follow the classical territory pattern of the great saphenous vein. Something is amiss. They are going from medial to lateral across the leg like that. That is across the thigh. This is not a usual picture that we see with varicose veins. On taking history, there was heaviness in legs as expected. She also had pelvic fullness. Any guesses from the audience what we are dealing with? Or is this just a simple case of varicose veins? We have follow-up for this case, so I know exactly what has happened. But if there's any guesses from the audience, if there is... So actually, we suspected there was something else at play. We did an ultrasound in our OPD itself. We saw there were multiple pelvic collaterals on ultrasound, like multiple venous channels in the pelvis. So we had a suspicion of pelvic venous congestion, that is pelvic congestion syndrome. So we got an MR venography for the patient, and you can see here left gonadal vein is completely dilated. That's the ovary, that is the opposite ovary, and there are multiple venous channels here that are dilated. So she actually had pelvic congestion syndrome, and because of pelvic varicosities, there was reflux into the lower limb, resulting in that atypical appearance of varicose veins in her lower limb. So we went ahead and did a ovarian vein embolization for her. Her family was complete, so we could go ahead with this procedure. And with that, she had relief of her symptoms. Case 2, extensive bilateral lower limb varicosities in a 60-year-old male patient. However, there was something atypical. So what is the atypical finding here? These varicosities are extending above the inguinal ligament. That should not happen if it is just lower limb venous incompetence. So again, we thought there was something else at play here, and we went ahead and did a venography for the patient. We got a CT venogram first to look at any anatomical causes, which confirmed there was IVC stenosis. So we went ahead and did an IVC venography, and we can see here that there is narrowing. This is the normal IVC. There is a narrowing here, and there's subsequent venous drainage. So we crossed that and did a venoplasty with the help of a balloon, and that resulted in symptomatic relief. Imagine if we had gone ahead and just ablated the lower limb varicosities in this case, and that would have aggravated the lower limb venous congestion. Case 3, left leg edema with distal pigmentation and a recurrent venous ulcer. So this is a classic picture of chronic venous insufficiency that we discussed in the beginning. We can see there is skin thickening, pigmentation, and just above the medial malleus, there's areas of excoriation. So the venous ulcer here has healed. So this would classify as C5 ulcer, according to the CEAP classification. While doing the screening Doppler, we saw that there was deep venous reflux in this patient. So firstly, unilateral varicose vein in this case, chronic venous insufficiency clinically. On Doppler, there is deep venous reflux. That is, when I'm asking the patient to do a Valsalva, the deep veins of the lower limb are showing reflux. So why should that happen? The blood flow should technically stop in them. So that again led us to think of something out of the box. We got an MR venography, which confirmed the presence of this syndrome, that is May-Turner syndrome, where your common iliac vein gets compressed. So this is just a graphic representation. This is your left common iliac vein, and the red is the overlying right common iliac artery. So your vein gets pinched between your artery and the spine, and that results in chronic reflux into the venous system of the left side. And this is May-Turner syndrome. So that's actually somewhere where varicose vein treatment is contraindicated. The patient actually came to us कि हमें laser करवाना है, is how the patient had come to us. And once he evaluated, we discovered that this is May-Turner syndrome, where it's contraindicated for you to do a varicose vein ablation because there's an element of DVT here. Because of this chronic compression, there's invariably some thrombosis in the left common iliac vein. And if that is the case, the superficial veins must not be ablated because there will be no other means for the venous drainage of the lower limb. We confirm this with the help of something called IVIS. IVIS is intravascular ultrasound, where we take a catheter. For example, this is the catheter here into the vein, and we confirm the presence of luminal narrowing. So here you can see this is the catheter, and the blue represents the slit-like iliac vein. That is, the iliac vein is completely compressed because of the overlying artery. So we crossed that after confirmation and placed a stent here. And you can see the luminal gain that has happened. That is, the lumen has expanded after the stent has come in, and the stenosis is resolved. So with that, the patient was doing well. And I'd like to show you take-home points for the treatment of varicose veins. Endovenous laser ablation is the standard of care for symptomatic varicose veins, that is C2 and above. Our goal is to catch the patient at C2 stage and prevent it from going to C5 or C6. That is, a venous ulcer must be prevented at all times. VenaSeal is the latest advance in the treatment of varicose veins management, and it's equally effective as endovenous laser ablation, if not better. For best results, case selection is ideal, and positive results can only be obtained if your right patient is selected. Briefly, I'd like to have an overview of deep vein thrombosis and where does endovascular management come in. So the mainstay for treatment is anticoagulation. In the generation of NOACs, newer oral anticoagulation, there is very little need for endovascular management. But when is that? Because that is crucial and critical. So I would like to highlight 3 indications. So we have heard these terminologies maybe in MBBS: phlegmasia alba dolens and phlegmasia cerulea dolens. These seem like one of the nightmares in MBBS that we were asked in the Viva. But actually, what do they mean? So phlegmasia means swelling. Alba here represents the color that is white, and dolens means painful. So painful swollen leg that is white is phlegmasia alba dolens. It is white because deep vein extensive thrombosis is present, but the superficial veins are intact and are draining the blood from the lower limb. Hence, it's white. That is, it is not completely congested. The second condition, phlegmasia, that is swollen, cerulea, that is blue, and dolens, that is painful. So painful, swollen, blue leg is phlegmasia cerulea dolens. Here, there is cyanosis causing the blue color because there's deep and superficial venous thrombosis. So there is no way for the blood to go back to the heart, and there's complete venous hypertension or venous congestion in the entire lower limb. So these are both dangerous limb-threatening conditions and can result in venous gangrene if there is extensive acute proximal DVT. Proximal means either iliofemoral or iliocaval, that is involving the iliac vein with the IVC, iliocaval, or iliac vein with the femoral vein, that is iliofemoral. These are strict indications for endovascular management and must not be left to oral anticoagulation or Clexane alone. Why? Because they can cause massive pulmonary embolism, they can cause venous gangrene and threaten the limb. And third is they have a high chance of something called post-thrombotic syndrome. So what is post-thrombotic syndrome? These are graphic images that show what post-thrombotic syndrome is. I don't think any of us would want our patients to land up with something like that has no treatment. Post-thrombotic syndrome is a severe form of chronic venous insufficiency that we discussed in the beginning, where there's extensive skin ulceration and excoriation and recurrent varicose veins that are secondary. So then our question would be, why not just ablate these venous, secondary veins that are found? Because they are the only way, they are the only channel for the venous drainage of the lower limb. So there is no treatment that we can offer here except for regular dressing, antibiotics, and some LIMC 500 TDS. That's the only thing supportive that we can do. There is nothing else that can be done if post-thrombotic syndrome sets in.
So our last 5 minutes up.
Sure. So that's why we must prevent this from happening. So how do we do that? So we have enough scientific data now that if there's acute iliofemoral DVT, pharmacochemical directed thrombolysis, that is thromboaspiration with infusion of thrombolytic agent, must be done in cases of proximal DVT to minimize pulmonary thromboembolism and reduce the morbidity from post-thrombotic syndrome. So ATTRACT trial was the one that actually gave us that information. So like we discussed, conservative management in the form of oral anticoagulation, but if there's proximal DVT, we must do catheter-directed thrombolysis. How do we decide on that? In lieu of time, I'll just go a bit faster. So pre-intervention workup, we must look at the exact extent of thrombus always. In all your DVTs, please make sure the Doppler reports are talking about where it is extending proximally. That is key. Second is selecting the right patient. Patients that have good life expectancy and a long life ahead of them, like a 27-year-old female on OCPs who develops a DVT. This is the case you must go aggressive. She has a long life ahead of her. So that is, for example. And then the third would be the endovascular treatment itself. Whenever we decide to take a patient up for endovascular treatment, first we start with an IVC filter placement. After the IVC filter placement, we go ahead with a pharmacomechanical thrombectomy. How is that done? So we have something called angiojet device, wherein we go in with this catheter. I'll just show you the video on the next slide. Yeah. Can we click play on this, if that's possible? We can just click on the, go on, it's not playing, okay. That's fine. So that's a video of one of the cases that we did, but okay. So the idea is to, yeah. So this, for example, yeah. So this here shows how much clot burden was actually there in a patient with acute iliofemoral DVT. And after angiojet, where we suck out the clot and infuse RTPA in the venous bed. So it's a dual hit hypothesis. That is, you're sucking out the clot mechanically and you're infusing a thrombolytic agent like Actelize in the bed of the vein, and we remove all of this clot. So ideally, I would have liked to show the video of that, but I would skip that. And to summarize, acute DVT, we have come a long way in its management with various endovascular options that must be used when indicated. That is in acute proximal DVT involving the iliac vein with the IVC or iliofemoral DVT. IR plays a key role in acute DVT management and in reducing the thrombus burden in establishing the venous flow. This is key to make sure that your lower limb does not land up in a venous gangrene or the chances of post-thrombotic syndrome and its severity come down. Best results of the endovascular first approach, the ideal patient selection is absolutely necessary for that. So with that, I would like to end my talk. Thank you so much.
Thank you very much, sir. We can take one question. Anyone? Thank you. I'd like to call upon Dr. S.N. Trivedi, sir, to felicitate. Thank you very much, sir, for the wonderful talk. We'll definitely like to hear you again.